Okay, so this was a relatively young or early middle-aged woman who came in with years of cyclic pelvic pain. And so on the top here, I've got the pre-T1 axial fat sac pre-contrast images. And on the bottom, I've got her sagittal T2 haste. And most of the findings are here, though I'm happy to pull up whatever other sequence that people would be interested in seeing. But anyone have any thoughts, like right off the bat?
So Amr is guessing an adenomyoma.
Okay.
Which I agree with, like
Yep.
a large posterior adenomyoma. And then on the T1 pre, it looked like maybe there was also endometrioma in the left, yeah, like over there in the left ovary.
Yes, yeah, so there's a bunch of little deposits that sort of look like endometriosis. Any other entity that anyone think of here? This is a little bit of a controversial thing, I guess, but it's something that one of my colleagues at Georgetown is sort of very interested in. So I guess the interesting part about this case is that, so yeah, it has a lot of these features that would make us think of adenomyosis, right? So this globular morphology, these cystic spaces, expansion of the myometrium back here. The interesting parts of it, though, is that there's this sort of tethering and deformity of the posterior part of the uterus back here, which sort of suggests there's an element of fibrosis back there. There's also the endometrial deposits posteriorly. And if you look anteriorly along the endometrium and junctional zone, it may not be as like crystal clear as the anterior junctional zone, but it's not sort of distorted or absent in the way that you might see in traditional adenomyosis. So we weren't totally sure what was happening here, but we believe there's a large component here of what is called deep invasive endometriosis. So endometriosis that arises from outside of the uterus and can invade a number of different things in the pelvis, including all the regional organs, the uterus, things like the bowel, bladder, vagina, and so forth. And the importance of that is that the treatment can change to some degree. So deep invasive endometriosis often requires some surgical component of treatment, especially if it involves adjacent organs. And so for these cases, we actually give rectal gel and actually try and give vaginal gel. This particular patient couldn't tolerate it, but we try and separate out the organs to see how much potential invasion there is with the regional organs, because you need to do surgery to treat that, basically. And then the uterine involvement can be treated potentially surgically, potentially with some of the same medical or laser treatments that adenomyosis can be treated with. And it depends a little bit on what the patient is trying to do, if they still want to have a baby or if they just want to treat the symptoms and are okay with a hysterectomy, of course. So at the end of the day, we weren't entirely sure if there was components of both in this case, but we think that there is a pretty substantial component of deep invasive endometriosis. And so it's just important to try and look around the pelvis and see if there's any other signs of invasion of other regional organs, and the treatment will likely be somewhat different than if it's just pure adenomyosis. So it's a little bit of a
controversy. It does look like the rectum is like kind of tethered on some of the sagittal images. Like that there's...
Yeah, we look pretty
right
carefully.
there.
It certainly, it certainly comes there. I think it's just sort of a loop that came around. I mean, we try to look pretty close, and the rectum does come right along some of those endometrial deposits. The way we reported it is we said it definitely contacted those. We weren't confident there was substantial invasion there.
Like right there, it looks like it's like involved, doesn't it?
You mean like in here?
Yeah.
Yeah, it was a little hard for us to tell because some of this up here was just looked like sort of collapsed, like you'd see from mass effect or just sort of normal underdistension. Mm-hmm. I mean, we've seen cases where there's sort of more clear invasion or tethering or stenosis of it. If you look at all the different sequences, let me see if the
I see Cookie's online. Cookie, do you have?
Hi, this is Cookie. Yeah, can you show me the axials? I mean, that's, I guess that one description is, this is really an adenomyoma, a focal adenomyoma, not adenomyosis. It's a, it's kind of in the spectrum of adenomyosis where it it becomes a mass as a big ill-defined. If you can just stop in the middle of the, yeah.
Cookie, one of the points Ross had earlier made was that it's not going all the way to the junctional zone. Like, for example, there, it almost looks like there's like a space between the junctional zone and the adenomyosis. So that's why they started pulling up the idea of like, maybe it's invading from the outside. Do you think that we're just being tricked by that potential gap between the adenomyoma and like the junctional zone?
I don't know, the sagittal looks like it's plastered on the junctional zone. I mean,
Yeah,
that sagittal is, I don't see any junctional zone there, so I disagree with that. I do think there is, right there in the axial, it looks like there is involvement of the torus that goes and obliterates that rectouterine space and involves the serosa. It's not deep, but there's definitely serosa. And then look at that beautiful axial view of those endosalpingiosis on that pelvic, right on the serosa of the uterus posteriorly.
Oh, cool. Yeah, that's like from your talk.
Yeah, that's all endosalpingiosis. Yeah. So she's got adenomyoma, endometriosis. She's got endosalpingiosis also in the serosa.
So do you think that there's any potential for deep invasive endometriosis here? I guess that's sort of the debate that we had internally at Georgetown about this case.
It's probably there. So there's your torus right there on your sagittal.
Mm-hmm.
And then go back to the axial.
Mm-hmm.
Yeah, I bet you there's retrocervical. I bet you there's going to be that they're going to have to go into that cul-de-sac posteriorly.
Yeah, I mean that's sort of the plan tentatively.
And where's the ureter? Do you see the ureter? Is the ureter dilated?
I don't think so.
Okay.
Yeah. Or is it some combination case? I mean, does it?
Yeah, it sounds like probably a huge adenomyoma and some deep invasive endometriosis between the uterus and the rectum.
Yeah.
Can it go straight from the adenomyoma out?
Usually it doesn't, it's not invasive like that. It's got both torus and adenomyoma. Got both, involvement of both.
Cool.
Can't say it can't happen, but usually it's both together.
Amr is saying bilateral hematosalpingiosis is highly specific for endometriosis. I believe that's correct. Yes. Very cool. Okay, who's next? I can go. Let me see.
Go, or I can go after you.
Okay. Oops. Okay, this is my first case.
Oh my goodness.
Young woman. So this is the axial. You can see that there's fluid, there's peritoneal enhancement, and then this is what her cervix looks like. And then there's also this kind of reactive thickening of the bowel. And this is the sagittal here. So any thoughts?
Cervical cancer, the invasion into endometrium.
Good thought. She's 18 and she was having a lot of pelvic pain. See, people are chatting. Somebody is asking, actinomycosis and Nabothian glands is what people have guessed. So we thought that this was probably just cervicitis, severe cervicitis in the setting of pelvic inflammatory disease. With some blood products that are trapped in the endometrium because the cervix is all engorged. I'll go back to the axials. And then we thought all of this was basically like kind of pelvic inflammatory disease with like peritonitis and then reactive bowel thickening. I had just never seen cervicitis and something this dramatic kind of looking. So I looked it up, and Amr's asking about Fit2 Curtis. Good. Actually, I did look at her liver. I can show you. I mean, she is having like peritonitis. I presume Fit2 Curtis is also when you see perihepatitis, which I did not convincingly see here, but.
You won't see perihepatitis unless you have a late arterial.
Okay. Okay. So maybe we just missed it, but she definitely has peritonitis. So yeah, I think it's in that spectrum. So anyway, this is what I looked up about cervicitis. So it's usually caused by the same things that cause vaginitis and pelvic inflammatory disease in general, although occasionally can be caused by radiation and trauma. The symptoms can be very nonspecific, although you can get some discharge, or it can be completely asymptomatic. There's something called cystic cervicitis, and that's when you get like rounded cystic lesions that have hemorrhage and debris within them. And then it's often occult on imaging. Actually, I found this radiographics paper from a couple years ago, but basically they said that, you know, there's very little literature about cervicitis. This is one of the cases they showed where they showed this heterogeneous uterus on ultrasound, and then it's kind of hypervascular on this ultrasound. But I had trouble finding too many cases. Sometimes they show cases where on MRI, the lining of the cervix is hyperenhancing, but it's pretty nonspecific.
How did the patient do after treatment?
They're still being treated, so I don't have the final diagnosis, but yeah, they are getting better with broad spectrum antibiotics. Yeah. Cookie, any thoughts?
Sorry, I was just getting consult. I'm like totally missed the question.
No, just like we thought this was basically pelvic inflammatory disease with like severe cervicitis. And in my literature search about it, it seems like it's often occult. We don't often see it on imaging, but it sounds like it's more of a clinical diagnosis.
And was she having blood? Is she on her menstruation right now?
Yeah, she was. So we thought this blood was kind of like getting trapped in here because of the swollen cervix.
Yeah. Do we have an ultrasound at all? You went right to CT?
No, we do have an ultrasound, and it was really nothing. I don't know. We didn't even focus on the cervix, so we kind of missed it. So I didn't transfer it over to the system.
Can you show me the axial just one more time? Sorry.
Uh-huh. And she has all this like peritonitis here, and yeah.
And any bugs going out yet still?
No, not yet. I'll follow it up with you guys.
All right, great.
Okay, this is my next case. This finding is in the stomach. Finding is this, and I will show you a coronal. So here it is. It's kind of like on a stalk. And it was actually really avidly enhancing like this. We actually did, I don't know why, but this was actually from an outside hospital, and they did the first one with contrast, and then they did the second one with oral contrast, so you can kind of see the opposite. So you get kind of you can see that it was enhancing on that post-contrast image. So there's the mass, it's on a stalk. So hyperenhancing mass on a stalk in the stomach. Any thoughts?
What's the density of the hyperenhancing? Like what, like?
It's pretty avidly enhancing.
And what's the age of the patient?
50. Kavya saying gastronomy. I don't know what that means. Oh, gastronoma. Yes. Good thought. So gastrinomas usually in the gastronoma triangle over in the pancreatico-duodenal groove. So it can be in the pancreatic head, duodenal bulb, etc. But this is something that could be related to a gastronoma.
Yeah, it's a neuroendocrine tumor, large neuroendocrine carcinoma.
Yeah, exactly. So this was a neuroendocrine tumor. Amar was asking about a paraganglioma, which is a good thought, but this was a neuroendocrine tumor. So just a couple of points about neuroendocrine tumors. So of the stomach, there are 3 types of neuroendocrine tumors. So type 1 is related to atrophic gastritis. And this is where it's often like these tiny lesions. They'll get biopsy-proven neuroendocrine tumor on path, but they're just these tiny lesions. They mostly see them in EGD. And the atrophic gastritis can be due to 2 different things. I'll tell you about it in a second. But these are like these tiny little nodules. They have a very, very low risk of metastatic disease. And basically, they want to try to treat the gastritis. So that's type 1 neuroendocrine tumors, and that's about 75%. Type 2, you also get multiple tiny lesions it's almost like neuroendocrine hyperplasia. And these are the ones associated with gastronoma and Zollinger-Ellison syndrome. Both of these, the gastrin level will be elevated. And then type 3, which is what we think ours is a single large lesion. They're usually greater than 2 centimeters. And these tend to be extremely malignant with like up to 100% risk of metastatic disease. So they're very, very, you want to definitely do an oncologic resection on these. Whereas these type 1s and 2s, you might take out the larger ones that are greater than 1 centimeter, but generally otherwise you're going to try to treat the gastritis. And one more point, so atrophic gastritis can be caused by either H. pylori infection or an autoimmune disease. So when H. pylori causes gastritis, it can either be like this diffuse gastritis that can lead to intestinal metaplasia and eventually cancer, or it can be antral predominant, and this can lead to a duodenal ulcer. And then the autoimmune type tends to be more in the fundus and body of the stomach. But either of these atrophic gastritises can also lead to this type 1 neuroendocrine tumor here.
I also have another comment on that.
Yeah.
The increasing use of PPIs and omeprazole that's over the counter is, shutting down the acid pump. So there is secondary gastrin levels just from a compensatory check and balances, if you will. Mm-hmm. So they also are increased risk of type 1 neuroendocrine tumors. So PPIs, and in fact, we should be looking in patients who have chronic PPI use for not only the hyperplastic polyps, the funded gland polyps that they get in the gastric fundus, but they are also increased risk of type 1 neuroendocrine. So that's something that we're seeing.
Cool. This case actually was a little bit even more interesting in that they actually had atrophic gastritis in the rest of their stomach, and they had like other biopsy-proven neuroendocrine tumors. And then this one came back. They did like a few big piecemeal chunks. They didn't fully resect it, and it was a lot of hyperplastic polyp with a little bit of neuroendocrine tumor. So we were confused about whether or not this was actually a type 3 or it was a hyperplastic polyp with a little bit of neuroendocrine. But they ended up doing a dotatate scan, and it was really hot. So we decided that we're going to treat it like a type 3 and do like a full oncologic resection of this entire lesion.
That's great.
Okay, this is my next case. This is kind of a consult as well. So this patient came in, you can see they're pretty sick. They've got portal vein thrombus here. They've got a hematoma that's causing a gastric outlet obstruction. And it's basically squishing the pancreatic head here. So, and then I'll just cut to the chase. This is kind of an eye test, but there is like a pseudoaneurysm in the middle of this hematoma that we thought was probably arising from a branch of the GDA here. And then as we went further down, they had all of this fluid in their abdomen. So acutely, the patient had a low hemoglobin. They knew that they had this hematoma, the pseudoaneurysm. They ended up getting that GDA coiled. But then the patient also progressively developed abdominal compartment syndrome. which basically they can put like they can check bladder pressures. So his abdomen was extremely tense, and they were asking us to do a paracentesis on this. And so one of the interesting aspects of it is just that this fluid, although it was measuring fairly low, it was like 25 Hounsfield units, and it looks fairly simple, was actually all blood. So this was the ultrasound for this patient, and you can see it was extremely complex. There was like lots of blood and hemorrhage in it. So sometimes hemoperitoneum can look like simple ascites if the patient is severely anemic. So don't just chalk this up to like that all of this is not blood. And then, yeah, and then they ended up, so right now, basically they put 2 large drains in here. Normally we don't drain hemoperitoneum or hematomas because we don't want to superinfect it. But because he had compartment syndrome, they ended up putting in some large bore drains because that paracentesis with all those septations probably wouldn't have been very successful. So my question to you guys is, do you think, we don't know what started this. He was having a lot of pain at home. And the question is, do you think, and I don't know, maybe we just can't tell, but do you think this basically started off as hemorrhage or like a bad pancreatitis causing a pseudoaneurysm and a hematoma? Or do you think this could have been from a perfed duodenal ulcer that caused this? I was favoring the pancreatitis because there's no air, but it's been going on for a little while. So I'm not sure I can tell at this point.
Do you have a venous phase?
No, not that I have to like upload these to a separate anonymized server, so I don't have it here. He did have all this thrombosis. What were you? I do have a venous phase like that I've seen.
So you think this is an alcoholic with chronic pancreatitis?
Yeah, he definitely has an alcohol history. We thought he had like either truncated pancreas. I mean, we didn't see definite signs of pancreatitis as far as like calcifications. But his liver also didn't look like it looked abnormal, a little bit nodular redistribution. Steve is asking, did the hematocrit density dependent favor ulcer unless, did show hematocrit density dependent favor ulcer unless prior acute pancreatitis? Okay. Yeah, I guess that was 2 statements. Oh, and then he's asking if there was any hyperdensity within the fluid. There was a little bit, like here, and that could have been a clue. And then also here, so a few areas that were more hyperdense, and then a little bit in the pelvis here.
And the Hounsfield units of the fluid overall is what? It looks dense to me just on CT here.
Yeah, let's see. Trying to get the Hounsfield unit thing. It's like measuring 16. I guess I've been tricked before. Like I had one like this where they were like, the paracentesis showed like frank blood. And I was like, no, it looks simple. And then turns out, the hemoglobin was like 6. And so, and then I read that like, if your hemoglobin is extremely anemic, then like your blood is going to be anemic too, Okay. I have one more quick case. So this is a patient who had this finding here, and I was like, oh, this is a great case of sclerosing mesenteritis. I thought it looked fairly classic. Big dystrophic calcifications, tethering bowel. But then this was their CT 3 months prior. Any thoughts?
It looks like a sclerosing mesenteritis.
This part we were thinking, well, so this is the 3 months, this is 3 months later, and then this is 3 months prior. So it started off with all of this nodularity, almost like soft tissue mass up here, not as much calcification. It's kind of cute, actually. They've got all these like varices in their small bowel here, in their duodenum and proximal jejunum.
I mean, is it a hemangiomatosis case again?
Nope. We did think about that. Like, is this lymphangiomatosis? Yep, Steve is asking, we thought about carcinomatosis. And then we were like, how did it all go away in 3 months? So anyway, long story short, this was all lymphoma. And it responded dramatically to treatment. And then this calcified portion, we think was basically like treated lymphoma. So treated.
So back to the original, it's got calcifications, right? Because you know, sclerosing mesenteritis has risk for lymphoma, right?
Yeah. So actually, I tried to go back even further, and going back to like 2013, some of these calcs were here, but he already had a history of lymphoma at that time. So I think that these were actually treated lymphoma. And then it exploded again this year, and then it got treated again and kind of like was mimicking again sclerosing mesenteritis. Your point is good. Like, did it start off as sclerosing mesenteritis and turn into lymphoma? I'm not sure, because the last one I could go back to, it looked already like calcified lymph nodes, and we had been calling it treated lymphoma.
Yeah, I mean, so that's the thing, because they get followed up the wazoo. Once we start saying, you know, sclerosing mesenteritis, and that carries a point when we see mesenteric paniculitis, not to call it sclerosing mesenteritis, even though it's in that spectrum. I'm just taking that as an opportunity for a teaching point. But once you say sclerosing mesenteritis, it immediately gets put into a GI follow-up workflow for cancer surveillance.
Yeah. Is it a high risk for lymphoma, Cookie? Because we follow up a bunch of these patients, and I haven't actually seen one turn from a sclerosing mesenteritis into a lymphoma.
They're actually increased risk of GI malignancy and lymphoma. So we've had a couple of GI malignancies, and I myself have not seen. That's why I was asking you. This would be a great case, because if you get from the very beginning of the sclerosing mesenteritis without lymphoma, can we get that imaging to show that this may have been something that was a nidus for lymphoma? But that's in their literature. It's in the GI literature as a high risk. So they actually get on the surveillance.
Yeah. We've been surveilling a whole bunch of them, and I don't know. I've seen a couple be very progressive and cause a bowel obstruction, and then they start going down the like methotrexate steroid, radiation route. But I haven't seen any actually turn into a cancer, so that's good to know. Cool. Okay, that's it for me.
Do you want me to go, Aarti?
Yeah.
Okay. Ooh, sorry. Okay, so this is an interesting case that we had a couple days ago. A patient came in with, this was an outside CT, and the mass was biopsied, and the path came back FNH. Thoughts?
I see like capsular retraction and stuff. I would have thought like either a malignancy or a sclerosed hemangioma or something.
Right, so there's capsular retraction. It's not great contrast, but you can see there's room enhancement on the early arterial and later phase. So really is a hard sell for a hemangioma. So we did an MRI, and this is what the mass looks like. It has lobulated appearance, again, capsular retraction. It has peripheral rim hyperenhancement. It has peripheral washout, right? It has target-toed appearance on DWI and hepatic. I mean, it hits every point on it being, somebody said, intrahepatic cholangiocarcinoma.
Steve said we biopsy.
So we have right. So then we're trying to figure out how is it possible that the FNH was on path. And check this out. So this is this is the central cut through the mass. This is the cut a little bit higher. You can see just lateral to the lesion. You see this kind of lesion, right? Hyperenhancing in arterial phase. Really can't see it on becomes iso enhancing on, sorry, I switched this around. This is the portal venous, this is transitional. Really just kind of becomes iso intense. Was not visible on hepatobiliary phase. So when we went back and look at the post-biopsy images that they sent us, you can see that the foci of air in the biopsy were just in the same area as this. So this is one of those cases where, if you try to do this, it would be hard to do, but somehow they ended up biopsying this little FNH and not biopsying the actual mass, which by the looks of it looks like a typical cholangiocarcinoma. So it was just an interesting case of, don't if pathology really doesn't fit the imaging features, you still need to figure out, maybe do rebiopsy or figure out why this happened. Okay, so that was case number. Anybody has any comments before we go on? Okay, so then here's another case. This was brought to us also from outside institution, and this is pre-early arterial and kind of portal venous phase images. And this was read as malignancy. Had the patient came in with diagnosis of malignancy. No prior history. Oh no, that's not true. Patient had hepatitis C, I think.
No prior treatment, like no local regional therapy.
Or no. Just I don't know how the mass was discovered, but this is how they came in. I know that there was no. It was not a treated mass, and the patient just came in with. I don't remember if they had cirrhosis, but I think they're sure. When it came to hepatology clinic, so they had some sort of, I think, chronic hep C.
Victoria, is it enhancing between these three phases? It looks like there is some nodular enhancement on at least on the final one.
So this is kind of the up and down images. You can see there's a little bit of capsular retraction. There's like this funny enhancement around it, kind of funny enhancing in it.
Sclerosed hemangioma. If I keep guessing it, I'll be right once.
No, this is exactly what I thought. I said I think this is sclerosed hemangioma. I couldn't really explain why I thought that. Like maybe Aarti, you can articulate better. So like I looked at it and like I don't know, it looks like sclerosed hemangioma, and I couldn't really explain why my eyes decided that. But that's what it looks like.
Two things that I think, the other one definitely it'd be nice to have an MRI like Steve is saying, but a few things for sclerosed hemangioma is if you see like a capsular retraction, which obviously will overlap with cholangio or any malignancy, a crumpled rim of a wall, and then this kind of more nodular, but continuous enhancement. Calcification can also be a clue. And then
right.
if it has like a triangular appearance, and then obviously if you have an old exam and you see it shrinking in size.
Right. Right. So I guess there's a little bit of capsular retraction. I guess you can make a case that some of
the other thing is
nodular
perfusion abnormality around it, like other.
Right. So perfusion abnormality. Right. So anyway, so the mass was biopsied a couple of times because they wouldn't believe it, but it is a thrombosed hemangioma. Well, no, I'm sorry, sclerosed hemangioma. I was quoting correctly. That was an interesting case.
Victoria, there's two terms. One is sclerosing hemangioma, and then one is sclerosed. So on PATH, I think the sclerosing one still has components that are alive. So you'll have a combination of like a typical hemangioma and areas of fibrosis. And then when it's finally fully sclerosed, which this one might be, then it's just fibrosis, and you don't have any other clues like regular.
Right. So this is reported as sclerosed hemangioma. But they went after it a couple of times because, at some point somebody said this is cancer, so they wouldn't take it. They wouldn't trust it.
Yeah, and when it's fully sclerosed, it's hard to get the diagnosis because all you see is like a sea of fibrosis, and you don't get those dilated vascular channels to even tell you.
I don't know. They kept saying this looks like a sclerosed hemangioma, but we don't know if you biopsied the right thing. Given that on the imaging you were concerned about cancer, they came back and they kept biopsying to make sure that they got biopsy right. So this is the opposite of the other case. I guess here the pathologist was concerned that, you know, we're biopsying something else other than the mass, but ultimately this is what it is, just sclerosing hemangioma. I think this is, okay. So this is at
wait,
20.
Steve asked about venous phase hyperemia. Is that a hemange thing? And generally, I think higher flow hemangiomas can have a lot of vascular shunting around them. So I do think that surrounding hyperemia is.
It's very common to have, especially for smaller ones, for flash filling hemangiomas. Almost always you will see, you know, some sort of perfusion abnormalities around them, and it can be quite obvious, very, very bright. All right, so this is a 20-something-year-old man, came in with abdominal pain, and you can see, you know, big spleen, very heterogeneous. This is portal venous anterior images, and this is the coronal. The thoughts?
Angiosarc.
Right. So that's what we thought also, angiosarc as the initial diagnosis. I guess somebody thought, could it be infarct? Sometimes we see infarcts in the big spleen, but I think that these hypodense areas are too mass-like, although, you know, for infarct, and then all this heterogeneity kind of is hard to explain just on the basis of infarct. Although some regions kind of look almost like infarct.
Tarun Pandey is asking about pileosis. Yeah, to me it looks like some kind of vascular thing, like hemangiomatosis or pileosis or something. Right. So that's also an indifferential. So, you know, patient has, it is splenic angiosarcoma. And interestingly, you know, this is the couple of case reports that I looked up or review articles. This is a very common appearance, like this kind of enlarged spleen with ill-defined mass-like areas. Splenomegaly is almost always seen. And then, regardless of the modalities we use, we see this complex mass with necrosis and hemorrhage. You know, MR necrosis hemorrhage is going to be heterogeneous signal, variable signal in T1 and T2. Typically no calcifications. Hemorrhage can be inside, like intratumoral, or can be outside, can be like, you know, you can have subcapsular, just retroperitoneal. And for differential diagnosis, there's quite a bit of overlap with other vascular splenic tumors, including hemangiomas, little cell angiomas, all these things. Lymphomas are probably not going to be this heterogeneous. Mets, I guess, possible, and then other rare sarcomas also consideration. So, you know, these patients need to go and get their spleens out. That's all I have. That's impressive that it hadn't metastasized yet.
Yes, it was actually confined to the liver. Interestingly enough, I mean confined to the spleen. Keep saying about liver. Confined to the spleen.
Cool.
It will metastasize. Unfortunately, they don't do well.
Yeah, like mostly to the lungs.
I mean, it's kind of diffuse liver, peritoneum. I mean, just kind of disaster. And within a year and 2 years, I've seen a couple of young people just die within 2 years.
Okay, anyone else have cases? Okay, well, it was great talking to you all. Thanks for coming, and we'll see you next week.
Thanks. Good cases.
Thanks. I know, now, Cookie, I need to get more of my more remote exams.